So patients with relapsed refractory myeloma have quite impaired functionality and quality of life, and so when treating them with agents you need to be quite careful in terms of a risk-benefit profile. I've been doing some work with an antibody-drug conjugate known as Belantamab Mafodotin, which is licensed and approved for patients with triple-class exposed multiple myeloma, of which the majority of patients, in fact all, were triple-class refractory. What we know about Belantamab Mafodotin is that it's effective in these patients, but one of the significant side effects is ocular. There is the formation of microcyst-like endothelial changes, which causes keratopathy and reduction in visual acuity and blurring of vision. What we've been learning is that for these patients it's very important to have active surveillance of these symptoms and ophthalmology reviews, and when these patients develop symptoms what you have to do is to interrupt treatment until there's resolution of these endothelial changes, and then you can reinstate the dosing. And by incorporating this sort of effect you can deliver this treatment over a long period of time. One of the questions we often get asked is that if you interrupt treatment, do patients relapse? But the analysis from DREAM2 suggests that the majority of patients maintain their response. The other piece of work is about trying to hear information from patients directly to try and guide their dosing. And what we discovered is that if you take their symptomology from a questionnaire known as the OSDI, or the Ocular Surface Disease Index questionnaire, that you can use that to predict whether a patient should stop treatment or not. So this may in the future replace ophthalmology testing, which is a real burden for patients, and we can then guide dosing of Belantamab Mafodotin based on their symptom questionnaire.